we have a large population of long-standing carnivores in our practice. And if you look at someone who's on a high-fat carnivore diet for a protracted period of time, they become extremely fat-adapted. And basically, their utilization of sugar is negligible. The cells are like, give me fat, give me ketones. And if you do a Kraft test on them, which is where you give them 75 grams of carbohydrates, and we do this for type 1 testing sometimes, their blood sugar goes up, and it stays up for a long time, but the insulin is very flat in the Kraft 5 pattern, which means they're not producing insulin, and they can't clear the sugar. Now, a type 1 diabetic, what would you do under those circumstances? You'd inject insulin, because it means you don't have insulin. And by definition, a Kraft 5 has to have less than 30 units of insulin as your peak insulin. So what would you do if you're a non-diabetic carnivore that has a Kraft pattern 5?
You tell me.
Well, I mean, what we've got to do is raise insulin levels. We have to get a response to insulin. And this is the conundrum that we have on the carnivore diet for long times. And a lot of folks, we debate back and forth, but especially if you're eating a lot of meat, the meat gets turned to, whether, carbohydrates come from two sources, ingested sugar or meat that gets converted through gluconeogenesis. So what we start to see is rising A1Cs. They're not eating any carbohydrates. We're starting to see rising A1Cs, rising triglycerides, very heavily fat adapted. They're always in ketosis, but their sugar numbers are climbing. And the reason for that is because they're equivalent to a type 1, relatively. And at first, we thought that the way to do that is, and this is what you said also, you were talking about this quite a bit, and it's the convention that we were treated with, that we were raised with, is that if you increase your blood sugar, you release insulin. So the obvious way to get sugar released is to be on a lean diet, no fat. So protein but no fat. And yes, their blood sugar went up, but it got worse, it didn't get better. And they were miserable, they got hungry. So we realized based on that blood sugar doesn't really trigger a significant rise in insulin. It's GLP-1 that does. So if you infuse sugar, you get a little spike, but a little bump in sugar, in insulin, but you don't get the massive rise. It's the incretins that allow for the release of sugar from, and that's a change to our physiologic understanding. But therefore, we've adopted the approach that in those people, we actually treat them with a small amount of carbohydrate to trigger GLP-1, to trigger insulin. Does that make sense? Yeah. The rationale when I listen to you speak, it just reinforces what we're doing and seeing, but it doesn't get better right away. It takes time for that mechanism to get better. So I know that there's a lot of folks out here that are flirting with on a carnivore diet. Carbohydrates aren't the problem, it's our relationship with them that is. And sometimes there is a time when, in my opinion, they are of value, kind of the Paul Saladino type, not quite that bad, but that kind of picture. So that was just a question that I had. Any response to that, or any thoughts on that?
Some people are using GLP-1 agonists as well, as you were saying before. Yeah. I'm not an expert on that aspect of the carnivore diet, I'm sorry.
Yeah.
Phil Ovadia, cardiac surgeon. So Rob, you quoted Dr. Bernstein and kind of alluded to the importance of blood glucose control for the avoidance of cardiovascular events. Ian alluded to, and of course we have a whole bunch of data showing that insulin exposure in type 1 diabetics over the lifetime predicts cardiovascular events. So I just wanted to get your thought on that relative balance between blood sugar control and insulin dosage, because if you're really only focused on blood sugar control, we could take the ADA approach and just say, well, just keep giving more insulin until you obtain that good blood sugar control. But I think it's really, you need to control the blood sugar with lower doses of insulin ultimately to avoid those cardiovascular outcomes.
I mean, I think that's what I tried to say in my talk, that I think insulin control is probably most important for the reasons that we have relative hyperinsulinemia, just because we have to inject the insulin into the wrong place. So I put a graph up of perfect blood glucose control and said, how how comfortable are you if that person was on 1,000 units of insulin to cause the blood sugar to be normal. But clearly in the real world, if you see what I mean, most people on a keto diet will take very little insulin. So I was trying to make the point that it's the keto diet that requires less insulin, but then you still need insulin to control the blood glucose fluctuations, because it's not just about food, as we all know. It's about emotion, it's about stress, it's about sleep and physical activity. So we have to be on it all the time. So I think we have to do fine-tuning of insulin, like people who don't have type 1 diabetes are fine-tuning it all the time, except they just don't know it. I mean, type 1s can tell you how your physiology works just because we have to put the stuff in.
I think, Philip, you're absolutely right. There's two components to the question that you asked. The first one, I think we're all in consensus, is that what you want to do, and the talk where I got trapped because Doug didn't give me enough, he took time off my clock, is that initially when you're dealing with someone that's insulin resistant and a type 1, you've got to get rid of the insulin resistance. So we go up to bring that gradient down. Insulin's required to decrease the blood sugar. And as you bring that gradient down, the cells recruit insulin receptors and you need less insulin. And our formula allows those people to go up to bring their average blood sugar down and then to go down on their insulin utilization. Well, a lot of these folks ending up, I don't know what you guys are using, but 20 to 30 units of insulin a day. And some even have to subfractionate their short-acting insulin when they're injecting it because they're so insulin sensitive. But the target is insulin sensitivity, and you're absolutely right. It is, you lower the insulin eventually on a ketogenic diet, but initially you've got to go up to come down. The second part, as it pertains to you with a cardiovascular risk, my perspective is that chronically elevated blood sugar, and that's why we focus on the A1C, is the primary determinant of glucose-associated cardiovascular disease, at least plumbing disease, atherosclerotic disease. I'm going to learn more tonight about the arrhythmia side. So an obesogenic person like myself has a 0 score because I can produce, at my highest, my fasting insulin was 87. Highest fasting insulin I ever measured in myself was 87. Well, you inject, and my blood sugar was below 100. You inject 87 units of insulin into me right now, I'm dead in a few seconds of hypoglycemia. But that's how insulin resistant I was, and yet my blood sugars were normal because I could produce a massive amount. Yeah. These folks can't do that or the Suze can do it now, but it wasn't able to do that before. So I think that from your perspective, from a cardiovascular perspective, its blood sugar is more important, low blood glucose, irrespective of insulin, which is kind of my fat period, and using insulin to correct that. Because what's going to kill you is, at least very rapidly, is your cardiovascular disease. The disease you get from hyperinsulinemia kill you slower. My biggest worry is my brain. I just want to ask Suze one question while you're standing there. I thought about this, is that, are you on steroids?
No.
Were you on steroids?
No.
For post-transplant?
No,
Okay.
I only, yeah.
Okay. I was just going to ask about the steroids and your blood sugar, so that's a moot point. Sorry, Phil.
Very good, thank you.
That felt like a drilling. But no steroids, thankfully.
But that's the classic transplant
Yeah.
thing. And obviously steroids are a big issue for diabetics.
It's really crazy, but as much as insulin is, taking insulin is a hassle. Honestly, I would much rather take the immunosuppressants. It does take a lot of fine-tuning, though, because every 3 months you have to have blood tests to make sure you're in a fine balance. And while a transplant is unbelievable, it's not an answer, because it's not like you cure everything. It doesn't take away retinopathy, all the other problems, but it certainly is an incredible change in my life.
Hi, Lily Johnston, San Diego. Thank you all for your wonderful talks. Dr. Cywes, for those patients that you have on GLP-1s who are type 1, do you believe that there is also a cerebral component or a psychological component that those medications are helping with the carbohydrate addiction and the stress piece in your treatment protocol?
Yes, we know that's been published, and we do know that. Now, when it comes to the GLP-1 use in the type 1s, I don't believe GLP-1 should or can effectively be used for a protracted period of time. So we use them sometimes, especially for the carbohydrate addiction or overweight patients, initially to do two things: to dampen that effect, dampen the addictive effect, and suppress appetite so they eat a little bit less. It also blocks glucagon, because type 1s produce no insulin, or at least some of them do, but let's assume they're producing no insulin. So there's no insulin agonist effect, which is what I was talking about with the carnivores, but it also blocks glucagon. And the paradox with type 1 diabetics is if their intracellular sugar, which is difficult to measure, is low, the liver doesn't recognize blood sugar, it recognizes intracellular sugar. Yeah. And if that's low, the paradox is that glucagon is going to be releasing sugar in response to an already elevated blood sugar. So if you suppress glucagon with a GLP-1, you get less paradoxical release of sugar in the face, from the liver, in the face of hyperglycemia. So it lowers the amount of insulin you need because you've got less of a glucose load going into the bloodstream. Then, so we gain control, we get those patients insulin sensitive, and we measure that. Then in those addicted patients, for the suppression, for the central effect, we then use, for example, if a young woman is having a period, that may be a rough week for her eating-wise, addiction-wise, so she may use the GLP-1 for that 1 week. If you go on a vacation, you may use it. So you use it as almost a stress response, or you can use it from time to time if you're struggling, if you find your insulin numbers are going up, you're struggling with that, if you've got a cold. They're beautiful drugs to use episodically. And I think the two folks on the stage will tell you this, is that nobody knows diabetes, and nobody manages it better than a diabetic. We doctors are sitting on the periphery guessing at what they're doing. So I empower my patients to have the medication available, give them the parameters, but I want my patients to become a better expert than I am in their own management using these tools.
Thank you.
Mm-hmm.
Hi, John Laspina, Boca Raton. What are your thoughts on the lifespan of the red blood cells of hemoglobins for carnivores? Mentioned what you said earlier, how carnivores who are consistently eating meat-only diet for a long time and the A1C rises. Is that because the hemoglobin is living, or the red blood cells are living longer? Is that part of it?
I'm not a carnivore.
If those of you watch my YouTube channel, you'll know what my favorite Latin word is. Anybody know?
Oh, I know that.
Yeah. But that's a Paul Mason
Is it?
thing. There are the hemoglobin, actually, it's interesting. There is a modicum of validity to that under certain circumstances. So, for example, someone who donates blood, they're going to have, when there's a rapid turnover, if you've lost blood, if you've done surgery and there's a rapid turnover, but those are acute situations. Or someone that's lost iron, that has low iron. But for the average person, for the average carnivore, the destruction of red blood cells by your spleen, by your liver, is very standard. It's around 120 days. Even if it's a little bit more, a little bit less, it really doesn't affect A1C that much. But yes, we do see A1C changes when you've donated blood, bled, or had a transfusion. Other than that, I really don't. And we look at other blood numbers, not just A1C, to correlate with that. So you'll see triglyceride changes, you'll see BUN changes. These are in the carnivores. You'll see other of the metrics change along with that. So when when these carnivores see the A1C going up, that usually correlates with an elevation in blood sugar, an elevation in triglyceride number, elevation in BUN, which denotes the conversion of protein to sugar. That's what BUN is. So we look at other metrics, and it's based on that I'll tell you that, no, Paul Mason is a little bit wrong in this regard. And you and I have had that discussion.
All right, thank you.
I wonder if I could just add something. I mean, I'm also not an expert on the carnivore diet, but just thinking about the gut microbiome, I mean, patients or people who follow a carnivore diet are eating differently. They obviously are avoiding fiber, probably having different exposure to some of the micronutrients. So it would be interesting to see what that is longer term. I'm not an expert, but I would think a lot of the research that we do know is it's your gut microdiversity that is an indicator of gut health. So I think from someone who has studied nutrition, to me, I'm not a massive fan of the carnivore diet simply because I think you need diversity. I'm going to be shot down, I understand.
I think you're absolutely right. Just one little Irish plug here, a person who's got a better Irish accent than you. Ira Cummins, for those of you who don't know him, the Fat Emperor, released about 2 or 3 weeks ago a brilliant video on a group of folks that ate carnivore diets and were studied at Belmont Hospital in New York for a year on a carnivore diet. And it's a short video, it's 11 minutes on Vimeo, but it is a brilliant take on the protracted high fat carnivore diet. And a paper came out of that on the biome. Mm-hmm. And the paper is linked in there, and I would urge anybody that's interested in the science behind that to go and look at that. That work comes from 1912, but Ivor did a brilliant job on that.
I'll certainly take a look. Sorry, could I just clarify for the record? We are South African, not Irish.
Well, actually, one other little thing. You're English.
Yes.
She's South African Irish. I'm South African American. We're the Americans. and I've got a thought on this. Where do you guys think the Americans are on the stage? I think if you look at our medical school training, we're so entrenched in dogma, and we're so fearful of crossing those standard guidelines things that it's very uncomfortable for a lot of American trained physicians to be able to buck the narrative that they're trained with. We were raised, I think all three of us, to ask the question why more often. I don't know, what do you think? What do you think in that regard?
I see my training as, I wouldn't say it's indoctrination as such, but there's a lot of facts to learn, and being a professional, you have to think in a certain way. So I was trained to think in the right way, the same as the rest of my profession. We are always encouraged to keep up to date with the science, but as a primary care physician, as a generalist, I still keep up to date with type 2 diabetes management, which is a primary care sort of role, and all of the advice is high carb, low fat, and then I can tick off I'm up to date on that, even though I never practiced that, but we have to get up to date on it. And it's similar with things like migraine. The conventional management is various medications, and I had a patient once who I treated with a keto diet who had really bad migraines. They'd had migraines for 11 years after head injury. They were having Botox injections every 4 months, and I talked to them about keto diet, and they went on it. 3 months later, they didn't need any Botox injections, and they're off all their medication and living a normal life, got rid of the sunglasses and all that sort of thing. And when we do our appraisals in the UK, we have to write up sort of case histories, and my appraiser said, well, I'm not really letting you have that as medicine, because it's not what we do as GPs. And I thought, well, what do you want me to do? Go on a course on how to prescribe medication and how to do Botox. So I think we're trained in the same way as everyone else. We're trained to think in the model that we're given, and those of us that think outside the box. And I think this is why a lot of my fellow clinicians are worried about going off and doing keto or recommending keto to their patients, is that the penalty if it goes wrong is great. You get picked off and you get sort of sidelined, and that's your career finished, really. So, look at Tim Noakes, for example, and I think a lot of people fear that that's going to happen. So we tend to stick with what we know, and so I think our training is relatively conventional, even though we're encouraged to think outside of the box. It's not really something that's practical.
If I could perhaps add, my background isn't at all medical. As you could see, I did marketing initially. My day job pays for my night job. So my day job is about questioning. If I see an anomaly in any of the data, if I don't ask questions, I would be fired. Why are these customer data statistics different to what we were expecting? And so I find it quite strange entering the kind of medical field, and I have people telling me this amazing result that they're having, and then they go to their doctor and they show these amazing results, and their doctor isn't questioning, like, why are you having these amazing results? So to me, as someone who isn't medically, my background isn't that at all, but I come from a real passion and a personal interest in the topic. I agree. I do question, because I feel we need to push the boundaries, and it's not right that we haven't. I mean, if we're seeing some great results, like why aren't people asking, how have you achieved that? I want to learn from you. It's almost like, again, maybe it's our ego that gets in the way or whatever, but if you see something great, why wouldn't you want to learn from them? My day job is I run a global mentoring program for 310,000 people. My whole life is about getting people to learn from people who've gone before. So I hope that we will question more. There, that's my statement.
So I'm Denise Force, an endocrine nurse practitioner. My question is, all of us that prescribe are pretty familiar now with GLP-1s, which you've spoken about. The only other approved medication for type 1s, which is somewhat similar, would be Insulin. And I do not see much use of that at all. I mean, it seems to work in the same way as GLPs with the glucagon suppression and hunger control and possibly calming down food noise. And why are we not using it?
I think it's a great idea. We can't get access to it in Europe. It doesn't exist on our formulary. But Insulin, amylin, is co-released, isn't it, with insulin in the beta cell on stimulation. It goes to the stomach and tells the stomach, stop eating, and it stimulates glucagon if insulin's overacting. We can't access. I think it's a great idea. I think it's under-researched in the sense that it hasn't become popular.
But here we can. I mean, it's approved.
Yeah.
I've prescribed it, but I mean, people don't stick with it because it's dosed 3 times a day with your insulin. Is that the reason? I mean, is that the main reason? I don't know any other reason. I don't see many people asking me for it.
Well, I can't answer that because I'm not from the States.
I can tell you that it's coming. In this country in particular, more so than, only America and New Zealand are allowed to advertise medications. There's no other country in the world that ethically allows the advertisement of medications. Just those 2 countries. And I can assure you, working in this field, that amylin analogs are coming. Eli Lilly has developed one. It's in production and testing right now. And as soon as they put money behind the noise, everybody's going to be using it. Amylin's coming, the glucagon antagonists are coming, or glucagon receptor agonists are coming, and the GIPs and the DDDP4 combinations, GGG, if you Google that, you'll see the initial results of that. So we're waiting for the SELECT trial data to come out, which is the GLP-1 agonist for cardiovascular disease, and then all these other molecules are going to come. It's available. Nobody's talking about it because it's not FDA approved for certain of these indications yet, and especially the weight loss one. That's where it's going to be used. It's targeted for weight loss.
You feel as if that will be geared towards type 1s because that's the real limitation here.
It's going to be geared toward obesity.
Yeah,
okay.
That's where the money is.
I mean, if you look at Wegovy, it's semaglutide. It's geared toward obesity. Mounjaro, tirzepatide, obesity. Ozempic, semaglutide, same molecule, geared toward diabetes. It's the indication that the FDA slaps on it when they ask for it, and it's all about money and economics. I use GLP-1s for Alzheimer's. I use it for PCOS. I use it for my cardiovascular patients. Have been using it for years, with significant data improvement, even though it's off-label in those indications. So the amylin is coming, and you'll hear a lot about it in the next 2 years.
Thank
you. John Cripps, retired ophthalmologist, a little north of Toronto. I know your work, Rob, from your PhD. So my question is actually for Suzanne. You mentioned after your transplant, you had the retinopathy. It didn't reverse that, if I understood that. Did it slow or stop progression? Would be my question.
Definitely. I used to have laser treatment at least, once a year maybe. I haven't had it for the last 7 years. And in March this year, it will be 8 years since my transplant. So it has been incredible. Strangely, it did take some time because after the transplant, it took some time for my eyes to kind of settle in this new sort of homeostatic environment. I mean, I'd had this really strange blood sugar environment being on dialysis, and I think that plays a lot into the unsettling of vision and things. So it took about a year for it to settle down, but it definitely is a lot more stable now.
Happy to hear. Thank you.
Can I ask you, do you see, or what are your comments on the reversal of diabetic retinopathy in diabetics who attain better glycemic control? Are you as an ophthalmologist seeing reversal, stabilization, or just slow down of the progression?
The problem is no one's looked at that. However, there's good data on all of the major trials. So all the drugs, the thousands of injections I've had to give, the anti-VEGF drugs, as you look 5 to 10 years out now from some of those major trials, the diabetic retinopathy, not only did we get your proliferative retinopathy or your cystoid macular edema, the two major things we worry about with vision impairment and blindness, better in most cases, but we dropped your level of retinopathy, so we stage it, so 3 grades lower than what it was. So back towards no retinopathy, and it's still that way 5 to 10 years later. But no one seems to have an interest in looking, and please, if anyone does, to take patients who you've reversed would be an awesome thing to do to show what a great biomarker by doing therapeutic carbohydrate reduction or whatever, or your program, and show the same thing as the drugs that I have had to inject way too many times in people. That would be fantastic.
Yeah, that's a very good opportunity.
Can I just add a comment to that?
Yes.
What Suzanne said is quite reassuring, because I don't know about yourself, but when we convert sort of people to keto who are type 1, there are certain things that I certainly, and I think most doctors, worry about is complications. And we do know that if people change their diabetes profile dramatically, sometimes with those tissues tenuously hanging on to glucose metabolism, if you take that away from them and convert them to keto metabolism, sometimes that makes things worse.
Yes.
And mostly it's transient, they say, but I don't personally want to take that risk of making it permanent. And so we would advocate a very slow transition to keto, but of course when you have a transplant, you've got an instant transition to a non-hyperglycemic environment. Do you personally find, or have you found in your career, that worsening when people suddenly improve their diabetes control? Yes,
if you do a rapid, someone who's had poor glycemic control, A1Cs of 13, you rapidly improve them, about 5 to 10%, and the studies show that as well, will transiently get worse for a matter of months, but they improve over time. So overall, you're far better off to do what you're recommending.
Yeah, thank you.
So that's how to do it. You get the speaker to ask you a question, and then you can and then you can speak as long as you want.
We're all learning from each other.
Yeah, we're all learning. I think that's the important thing, and we're all questioning.
Eric Westman, Durham, North Carolina. Ian, so let me just, you ran 20 miles a day. 5 days in a row. Drinking water, having electrolytes. No food.
Nope.
So you didn't carb load.
Nope.
Just saying, you didn't carb load. You didn't fat load.
No.
You didn't eat anything.
No.
Did you take insulin during that time?
The insulin requirements dropped, and we had to be good at that. We were both of the type 1s that took part, we were a little bit concerned about stepping down insulin, because when you're not eating, you somehow don't need as much insulin, and that's why we practice fasting. We did, I think, 3 or 4 4-day fasts to get used to stepping down insulin quite quickly, and after 48 hours things had stabilized quite a lot. So there's one day where I took no insulin whatsoever, but I'm on Tresiba, and that was probably taking over the control.
Was it the same for the other type 1?
Yes. I think John stopped insulin completely. I think he abandoned his long-acting and just worked on rapid-acting for himself.
Do you recommend that people try this at home?
Well, we did it to show that it's a safe practice. So I think they should actually stop breakfast.
Are you ever going to do it again?
I'm not sure yet, really, but it's quite an undertaking. It wasn't done as a stunt, and we just did it to prove something.
Yeah.
It's quite hard work, and I think it probably puts a stress on the body at days 4 and 5. So I wouldn't be planning to do it again, but we wanted to do it once just to show that it's possible.
Well, I'm so glad you wrote down what you did, and we got that into a medical journal.
Thank you very much for
Fantastic.
inviting me to contribute. Yeah.
Can I have one question per person, Doug? Maybe, okay, no one behind me, thank you. I have approval. So I had eating disorders. I was at a meeting like this. There were 5 of us around the table at lunch, and I looked around and said, if we had a traditional dietitian here, they would say we all had an eating disorder. I think Rob, you might have been there. You're just eating meat, and you're not eating anything, and you're picking around your food, and it would look like an eating disorder. What is normal eating? I think we've come through an era of our lifetime where everyone's having disordered eating because they're eating the ultra-processed sugar and ultra-processed food, and that makes it look like you have to have meals all the time, you have to be hungry, you have to graze, you have to have breakfast. No, you don't. So what is normal? And I'm glad you brought up the idea that new questionnaires will have to be done. Often there's judgment inside these questionnaires, and judgment about what's right and wrong. And it's almost like, the first half of my career, I'm trained as an internist to diagnose people, you're right, you're normal. Now I'm trying to get people out of this sort of false thing of being normal or abnormal. Yeah. And if you're getting great nutrition, you're feeling well. In fact, over the lunchtime, I can't believe it. I said, you should just don't tell your doctors what you're eating, and the response from these earnest patients with type 1 diabetes was, well, that would be keeping information away from my doctor. I need to tell them. And I said, no, you don't. Well, because they don't know what normal is for someone who has type 1. In fact, there should be a language called grit speak, perhaps, where, do you know grit speak? What's that? Right then. I'm following a Mediterranean diet. But what's normal? So the microbiome, I have to credit Amy Berger, Tuit Nutrition, my co-author on End Your Carb Confusion. And we would, working on this book, we would put, not the microbiome again, no. It was like chalkboard, fingernails, and Norm Robillard, who wrote a book called The Heartburn Cure, unearthed a paper 100 years ago, like we're all unearthing now, where this researcher changed the food and the microbiome changed as a result of the food. And now everything is being reconstructed and you get funding. And when my colleague at Duke said, Eric, I got funding, I said, what's the grant? I said, the microbiome. No, not the microbiome. So of course it's going to change with what you eat. And if you get under the old world of what's right and wrong and normal is what we usually see, and it doesn't necessarily mean optimal, does it? So when I saw the world's expert on microbiome showing the tropical rainforest, just like your picture up here, the rainforest, nettles, that was an interesting picture. It was like you didn't want to walk into that area. The rainforest, to me, this is the microbiome. When you eat a mixed diet, I'm like, a rainforest, things can kill you in there. They're poisonous things. And then he says, on a low-carb diet, there's not a whole lot done, but click, a new slide, it was a desert. And he said, oh, look how just terrible, barren it is. And I thought, well, actually, it seems kind of calm to me. and I go out to Arizona, I want to, just sit around and meditate. I was out in Arizona the week later, and in a conference like this with people, I said, is the desert beautiful? They said, yes, it's gorgeous. And so the perception of what's normal and abnormal, right and wrong, and all, it has to all now kind of be reshaped toward what's the end goal? What's the end result? It's not the process. It's not the food intake. It's the end result that your A1C is now so low, they think that you need to raise your A1C. Wait a sec. So anyway, I've had to reconsider everything that I thought was normal, and now I help people understand no, it's not normal. It's okay, and now it's probably a new physiology entirely, so our normal range, even on blood tests, is going to probably be different. Wow, that's hard to explain to a guideline-following doctor, a U.S. doctor.
Yeah. If I can add to that, I mean, normal is an illusion. And even if you go by the WHO statement of, what is health, it's not just an absence of disease or infirmity, but it encompasses everything about the physical, the mental, and the social. And so eating is all of that. We don't just eat because we're hungry. We eat because we're with friends, because we're stressed. And so I think the definition of an eating disorder is when it impacts all of that. So your social, your physical, and your mental. And so even though it might not be defined within a strict DSM-5 guideline, if that affects your life in such a way that you aren't functioning as a healthy person, then I would define that as an eating disorder. And so if you are eating in a way that makes you feel like this is helping me cope within my environment, and even, that gentleman in the last statement that said, eating disorder, is this an eating disorder when it's somebody who's looking after their health? Then if that's what's helping them to function,
I look forward to your next PhD thesis, which is to come up with a new questionnaire on how to gauge eating disorders. I love it.
I'll partner with you.
Hi there, Kirk Wolak, just local. You mentioned diabetes burnout, and listening to Lester talk about how the doctors look at what his son's doing and think that's impossible, that's really hard. I thought of that phrase now, and I changed it a little bit. Is it diabetes fatigue? Because we suffer decision fatigue when we keep having to ask a question. Like if you try to cut out of food for a certain length of time, right, give something up, and you're constantly asking yourself, can I have it now? Can I have it now? Eventually you get decision fatigue. And I thought about it, and I thought, well, that burnout, that's really like a decision fatigue of what am I tracking? How well am I doing? So the question in this is there a way that we can represent that as a way to present this information insofar as endocrinologists? Which level of decision fatigue do you want? What you put in your mouth 3 or 4 times a day? Or the 16 checks you have to do to cover the fact that you ate French fries and spent 7 hours going through it? So that's kind of my question. Is there a way to bridge that gap?
I'll leave it to the end.
To any one of you, I mean.
What are you saying is...
So the question is there a way to use that terminology, decision fatigue? Which decision fatigue would you want the patient to go through? The one about managing what they're putting in their mouth 3 times a day to reduce the number of decisions about how actively they have to stay on top of their glucose control, or the decision fatigue that comes from eating carbohydrately inappropriate for a type 1 event, and then having to make a bunch of decisions for the next 7 or 8 hours as they shift into panic mode.
Yeah, I mean, I think Suzanne's paper and my own observations with people I know who have gone keto, I mean, the first thing they always say is, why wasn't I told this before? Because often going keto gives you control for the first time in your life, and that is a huge relief to most people with type 1, because the guy that says it's downhill from here, wow, that's great motivation, isn't it, to carry on? So you sort of know you're heading over the cliff, and that your doctors are trying to say, we'll try to rein you in if you do as we tell you. But then you discover this whole freedom, it's absolute freedom to eat when you like. And you're not a slave to insulin management at all. You have to be careful, but it's not difficult because you know you can control it. Whereas if you have a bag of fries, you haven't got a clue what's going on. And as you say, or if you do a lot of sport in the evening, you're going to have to be monitoring your sugar throughout the night to make sure you don't have a high pain in the night. How ridiculous is that? Whereas if you're on a keto diet, you don't even worry about any of that. You just carry on as normal. So yes, I think decision fatigue is greater when you're on a more complicated dietary regimen. really, because you've got all the other aspects of the pillars of health to look after, irrespective of what you're eating, and you know, eating the one food that stimulates insulin and can't guarantee the absorption rate. You can't guarantee the absorption rate of the insulin you're putting in to hope it's going to hit that peak at the same time. It's very, very difficult indeed, and it leads to this overestimation of insulin. Everybody knows, you know. So yes, decision fatigue is greatly reduced when people have got easy control of their diabetes. So you can fast all day if you want to. You don't have to worry about it, or you can eat keto meals regularly and just put in a tiny bit of insulin just to keep yourself controlled. But that isn't stressful because you know you can actually do it, and you know you're going to get a good flat trace. But it is stressful when you're thinking, you know, if I'd had a big lunch of carbs and shooted up a huge amount of insulin, standing up here for 3/4 of an hour, am I actually going to go hypo? You know, what's that going to be like? You know, and that is a thing that you face all the time. I mean, I remember having a hypo when a patient walked in, plonked themselves down, and they burst out into tears. I thought, cracky, I've got 20 minutes with this person, and I'm about to go hypo, and I won't be able to ask the right question. I'm not doing my best by this person. So I sent them out to give me a urine sample and gobbled up as much urine, as much glucose as I could, and recovered the situation. But then I had a high, if you see what I mean. That was when I was in the good old days, or bad old days, of high carb diets. So, and that is very stressful when you think, am I about to go hypo any minute now?
Right.
Yeah. Thank you.
Thank you.
Gosh, that sounds stressful.
Yeah.
Dr. Lake, I wanted to direct this at you since you spoke on exercise, but any advice or even caution that I should give a patient who is wanting to venture into cryo or ice baths in addition to their regimen?
I don't know enough about it. I think ice baths suppress insulin, someone told me, but I'm not an expert on ice baths, but it's not something
Seems to be
I do
gaining
every
popularity,
day.
and I'm getting questions from patients.
Yeah, I mean, I don't think that'd be a major problem, because how long are you going to be in the ice bath for? 5-10 minutes? It may stimulate a stress response, but I think it's meant to reduce your stress response, isn't it? Mm-hmm. By stimulating your vagus nerve. So I would just say, see what happens, and for you personally, you'll have to adjust your insulin to suit, or be prepared to take glucose to suit. But I don't know enough about the physiology of ice baths, and I've not got into the Wim Hof stuff myself. But I know a lot of people start plunging into ice as some sort of. I prefer hot therapy rather than cold.
You're from England, of course. You prefer hot.
Thanks.
We got a few questions from the live stream.
Yes, shout out for the people watching all over the world on the live stream, by the way. Thanks for joining us. For Dr. Cywes, could you comment on the range of tests that you perform, like C-peptide antibodies on intake?
Yes, so I've got a large number of tests, and one of the things that I really preach very heavily is, as a preface to this, is healthcare has become more and more anonymous algorithm based, where doctors have a single algorithm and they try to plug every patient into that. One of the things that I pride myself in my practice is that I take enough time to get to know you as an individual, so that I know who you are and what I want to know about you from your blood work, and it's slightly different for everybody. But my standard test, and actually with Isabella Cooper, one of you showed me Isabella Cooper that paper. I've also added something else, but I will look at C-peptide, insulin, fast, and it's always early morning fasted. It's the worst blood work you have, and it tells me about how your body did with what you ate last night. Because you don't just get rid of that food, it hangs around for a while, especially if you're diabetic. So early morning fasted, I'll do insulin, A1C, fasting blood sugar, and I do a glucagon on everybody. But then I do a lipid panel, just a 4 or 5 lipid panel, none of the NMRs or anything like that. And then I do a CMP, which is going to tell me about calciums and liver numbers, and also a CBC. I'll then also do hormones. I test testosterone in females. I'll do a PSA in males. I do an H. pylori, which can affect stomach function as well. And the one that Isabella added in was IGF, IGF-1. So, and then occasionally we'll do a CRP. I don't do any ratios. I don't care about ratios because if the opposite numbers are up or down, it screws up a ratio. And I also don't look at individual numbers. I use my blood work to tell a story. So if your iron is low, why is your iron low? Did you just donate blood? Do you have thalassemia? Do you have a bleeding disorder? If your BUN is high, that's not about kidneys for me, that's about protein. If your uric acid is elevated, are you eating fructose and wasting fructose, or is that a protein waste product? So I interpret blood work in the context of everything else. If your triglycerides are high, why are they high? And what impact is that? What's your A1C if your triglycerides are high? So it's a read. And it's very difficult for me to answer that question. I've got to get to know you as a human being before I order tests. But remember this, most doctors order blood tests that have no value to their patients. They're to check boxes on an algorithm so they get paid.
Good point. Thank you. This is directed at you, Dr. Cywes, as well, but I'd be interested in if it's different in the UK. In a patient that you get their A1C lower than 6, is there a ICD-9 or guideline recommendation for charting and showing them in remission? Or is it like a lot of her colleagues are saying, once they have a type 2 diabetes mellitus diagnosis, it's always on their chart?
It's an excellent question. It's actually ICD-10. And the code that I most often use for diabetes is the 1065, 10.65, E10, I think it's an E, 10.65, which is easy for type 1s, because you're a type 1 whether your A1C is 4.4 or 12. But for the type 2s, 6.5 is your threshold. So I use an R73.03, I think it is, which is insulin resistance. If your A1C is above 5.2, and that's the code that I typically use for my IR patients. Then I use the E1165 for my type 2s, true type 2s, and then E1065. 65 means they're comorbidities, but it's impossible to be insulin resistant and not have comorbidities. One thing to add to this is that you mentioned earlier on, I think you were talking about treating your type 1 diabetes. The first thing I tell my type 1s is, I'm not here to treat your type 1. I'm here to treat your type 2. And everything about the insulin management and diet management is treating type 2 diabetes. Your Traceba is basically managing your type 1. And then your diet, the dietary side, the psychologic part, the stress management, the sleep, the exercise, and then also the insulin dosing is there to curb type 2 diabetes or insulin resistance. And that's why you are better armed than I am. Because I got to wait for this darn thing to work, and it may whip the pancreas. You can go, hey, here I am. So that's the value.
Yeah, I think in the UK, 6.5% is a threshold for remission of type 2, and we continue to monitor. There's no payment involved in the UK. It's the National Health Service, and we continue to recommend monitoring of people with remission. For as long as, for life at the moment, until we get better information that it's safe to let them go, because there is carb creep in people who go into remission of type 2, and I showed a slide of retinopathy saying that less than 7%, 3 to 5% of people at that level do get retinopathy, and that's in type 1. But as you're saying, type 1 becomes type 2 with a hyperinsulinemia. So I would be very careful. Carb creep happens to people with type 2, because when you have type 2, you don't have to do much. You feel okay. Your doctor says you've got type 2 diabetes. Oh, have I? I feel okay. And then so don't eat this, don't eat that, don't eat that. And then you go out with your friends and say have some sweet stuff with a coffee, and then you think, I actually feel okay. Because in the UK, we're not encouraged to test as type 2s. If you see what I mean, there's one paper came out say, whether if you test or don't test, and test strips comprise a large proportion of the total cost of diabetes drugs, and they say we don't get any difference. Well, that was in the days of high carbohydrate diets. Now, at the surgery I work in, we offer our patients one Libre 2 who have advanced pre-diabetes or diabetes, offer them a program, and then they can learn about the blood glucose and go into remission. But yes, we at the moment we're monitoring people because carb creep happens. And
I think that's where the biofeedback of the CGM comes in. It's not just to monitor the number, but it tells you right away what you did.
Absolutely.
And even if you exercise, now for me it goes up rather than down when I exercise, my blood sugars, but it's feedback.
Yeah. And
that biofeedback is for most of you have biohacked blood sugars and CGMs from time to time, so it's incredibly valuable.
What we do is give 5 days, we say 5 days eat what you normally eat, and then for 5 days eat what we can recommend you eat, based around what they like, and then that's the best learning, I think. We only give 10 days because these sensors don't necessarily last 14 days. So, and it works quite well, and it's hugely educational. We're getting lots of people into remission, and we're up with all the other studies that are getting people into remission in our surgery of 30,000 people.
Do you think it's possible to do what you do and not have a CGM?
No, I couldn't let that go. You're not having it. No, the CGM is, for me, it's the best thing since insulin. It is really so important. Really? I know I can just check my glucose any time I want to, and I get that alarm if it's going down, and I can see the trend. So it's the trend that's the key thing here, isn't it? It's the change of glucose. If you've got a normal glucose all day, it doesn't really matter, but it's when it's trending down, and you need to be on it, just to take 1 or 2 glucose tablets, nothing, 3 to 6 grams of glucose, just nudges it up a bit. And if you're going high, you can just nudge it down with a bit of insulin. You don't have to be obsessive about it. I mean, I inject straight through my trousers, I inject into my neck if I want to do a party piece. You just get on with it, put it in, and then it's done. And so it's not a difficult thing to do, but yeah, that's what I do.
And that's why it's just ludicrous. I agree completely with you that we have so many barriers to obtaining CGMs for our patients.
Yeah,
it is absolutely ridiculous.
But also, how fortunate are your patients that you are nutritionally savvy? How many doctors could guide their patients as safely as you can with dietary advice?
Well, I think that what we are is an evolving, that's what SMHP is. It's an evolving group of metabolic health specialists. Because more people die in this country of metabolic disease, and it isn't a specialty yet. And chatting with Tim Noakes, he started out and created, together with a few other people, the specialty of sports science. Before that, we really didn't know how to manage athletes metabolically. Well, he did that, and now we're at the forefront. That's my first slide, showed all those organizations, the journal, the organizations, everything coming together to create this as a specialty. And I think over the next 5 to 10 years, I would love to see this as a certifiable specialty. Lord knows, the majority of people are going to die in this country of the disease that doesn't have a specialty to treat it.
I do have one more question from Phil Thompson for Dr. Lake. In your talk, you were discussing more needs for insulin, insulin being required by type 1 diabetic, injecting it, and it hangs around longer. Does this show up on a blood insulin lab?
We can't get access to blood insulin in my country.
Yes, it does. It does show up.
It does show up.
Yes, that's why I check C-peptide and insulin. C-peptide will be like 0.1 or less, but you'll see the insulins. Yeah, so they are measurable depending on the test, but certainly LabCorp and Quest in this country will test for them.
Okay, thank you.
Starting to get some feedback. There you go.
I just looked into that. I'll just.
No, it should shout.
Does that work? Okay,
Yeah.
great. No yelling enough. So I just looked into that a little bit. Actually, most conventional insulin assays won't pick up on the insulin analogs. They'll measure human insulin, but not the Humalog, Novolog, Lantus, Tresiba, Levemir. So it's a little bit more tricky to measure those levels. And even if you could measure them, it's hard to understand, the action of it, right? It doesn't necessarily give you the information that you're looking for. If you're measuring a Lantus level or a Humalog level, those could mean very different things. So there are some research-based assays, though, that are able to distinguish some of the analogs, and more are coming out. So hopefully one day we'll be able to look into it a bit more closely.
Yeah, what we look at is we always measure C-peptide, and then we measure the insulin, and they're polar opposite parts of the body. One is at production, one is the end of utilization. One is venous, peripheral venous, one is at portal venous. The C-peptide measures portal venous. But we do see a positive insulin number in our type 1 diabetics who are producing no native insulin. And I don't use the absolute number, I use a change in number over time. So for me, it's the monitoring of the patient that's more important. Same thing with glucagon. We don't actually, none of the commercial assays measure specifically glucagon. It's glucagon analogs, but it still gives you a continuum over time. And the reason I like glucagon is because it tells me how hard the pancreas is, how hard the liver is contributing to your blood sugars. And it tells me about gluconeogenesis in the face of insulin. So when I look at all of those numbers as a collective, I'm able to understand the pattern of this person's metabolic function. And part of it is the liver controlling their energy utilization, or in your case, it's your fat cells that are controlling this. Yeah. It's your lipid release. So your energy traffic is fat cells to body. Most people on an American diet, it's liver to fat cells and liver to body. So the traffic, the direction that traffic flows, that energy traffic is also important. And some of those hormones help us to analyze that. But you're right, it's not every analog is measured.
Right. And so you're able to look at the insulin in the context of glucose and like food intake leading up to it and exercise and all these factors?
Yes. Yeah. And I think what Eric said earlier on is the normal ranges are very, very different. Your normal range for insulin is 1 to 24 on some of these assays. My normal range is below 6, ideally 3 to 4. And it doesn't matter if you're a 1. It's, again, tracking those numbers and seeing them come down. And then in 2s and normal, non-diabetics, not normal people. No. Sorry, normal people. It's okay. Non-diabetics. We can correlate that with C-peptide as well.